indiscretions or foolish business investments, is what the DSM-5 says. So this is classic mania. These are the symptoms. I highlighted distinct period and irritable because we're going to touch on those as it relates to differential diagnosis here in a second. I know that our case had all these because I built the case to have all these, so that's so atypical that I had to just build it myself. So there it is. So here are the sticking points. First, the time criteria. Some would argue that children don't often meet the criteria for 1 week of a manic episode, that they have shorter periods of time where they have this elation, grandiosity, etc. The NIMH Roundtable has basically said, no, that's not true. We're just going to follow the guidelines. And I think that in the end, for us right now, that's probably the best thing to do. A change from baseline. And so this is the trickiest part. I think this and the distinct period become the trickiest part. So for kids, sometimes they're sort of in this state a lot of the time. And the idea of how do we tell what their baseline actually was. So for many children, the mood problems seem to be their baseline functioning, and there's no real sort of change that you're noting. So are they still bipolar? And if you talk to the NIMH, they would say, no, you need to see these symptoms that fluctuate, right? You have to be at a baseline. They fluctuate with these different episodes. And that's how I feel about it as well, that I think we need to see episodes. If you don't see episodes, we're probably not looking at bipolar disorder. And that's where this distinct period comes in. Most of the time when we're trying to make the diagnosis of bipolar disorder, we're trying to see that there's a change from baseline in a discrete period, and usually, not always, but usually that then comes back to that baseline, and sometimes that goes below it, right, into a depressive episode. And then the last thing is that this is all really difficult when you start to throw development into the mix, right? So children at age 5 are expected to be less attentive, and almost all children have increases in goal-directed activity, and every adolescent boy has an increased likelihood of engaging in something with a high likelihood of disaster. So the developmental piece has to be incorporated into your assessment, right? So keeping in mind whether they are different or the same for other people their age. So at this point, turn it over to Chad.
Yes, I quickly wanted to discuss a patient that I had seen who kind of maybe more represented the typical case, as Dr. Althoff was saying. So just to give you some background. So Logan, he was an 11-year-old male with a long history of behavioral problems, difficulty at school, inattention, and insomnia. So just for some general background, he was born from an uncomplicated pregnancy. He was born at a planned C-section. He was the second of 4 boys. He had some slight delays developmentally, but was mostly on track. But as he kind of grew up, in the 2 to 4 age, he started to have behavioral problems. It was difficult to control at home. He wasn't really listening, wasn't really following rules. We don't have great documentation from back then from his early childhood, but by age 4, he was diagnosed with ADHD and was sent for referral to Peds Psych. And so he was followed by Peds Psych. Peds Psych also noted that he had some hand flap, stereotypical hand flapping, and his mom noticed that he would rock back and forth often. And he actually got the diagnosis of autism spectrum disorder. So he was followed through 2015 through this Peds psychiatrist. They tried to hook him up with all the resources possible. And by 2015, he had a lot of help at school and was eventually diagnosed with mood disorder, autism spectrum disorder, and ADHD. And then in 2015, they then moved to Florida. And so they spent 2 years in Florida and then eventually moved back to this area and was trying to reestablish in this area. So they reestablished with behavioral health. They were not seeing the same Peds psychiatrist that they had been seeing. They were now followed by a psych NP, and she tried to hook him up into therapy in the area and try to manage his medications. But he still was continuing to have behavioral problems, wasn't succeeding well at school. He had an IEP, but had been held back in 2nd grade, basically did not have any friends, wasn't socializing at all. None of his peers basically were essentially avoiding him. he became very depressed, wasn't really engaging with his family very much, was becoming more difficult to control. And so after trying to tinker around with medications, the psych NP decided to send him for a neuropsych eval. So for the neuropsych eval, it's pretty extensive intake. They do a lot of neurocognitive testing. They do a lot of various survey instruments that they give to the kid, that they give to the parents, that they give to the school. And the neuropsychiatrist noted that he once had an episode lasting about 3 days where he didn't sleep at all. He had always had trouble sleeping, but he basically didn't sleep at all. Had increased irritability, increased anger, increased aggression, was taking it out on the other kids, and didn't sleep so much that he began to kind of hallucinate. He was seeing things that other people weren't seeing, and when people would bring that up to him, he would get really upset and start lashing out at them. So she ultimately diagnosed him with bipolar disorder and ADHD, and said that he was not autistic. The testing revealed that he was not autistic. So that's kind of how he returned to psych NP, which is then she tried to adjust his medications appropriately, but nothing seemed to really be helping. He kept being aggressive, kept having difficulty at school, and nothing seemed to really be helping. And then during that time period, he threatened the kid at school and was sent to Glens Falls Hospital for evaluation. He was not admitted, but he spent the day there, at which point the psych NP decided, but this was also compounded by the fact that he kept missing appointments. He would either cancel the same day or would just not show up. And so he had missed a number of therapy appointments. So the psych NP decided that he needed a higher level of care than she could provide and sent him down to see a ped psychiatrist down in Troy. So the ped psychiatrist saw him, and after kind of reviewing the chart and listening to their story, decided that it didn't seem like it was bipolar. Maybe that episode was triggered by something else, and ultimately diagnosed him with oppositional defiant disorder, anxiety disorder, ADHD, and learning disabilities. And then, after seeing the child about twice, the mother basically called the psych NP again and said, he's doing a lot better now, and we can't keep making this trip down to Troy to see the psychiatrist every time. Can we reestablish with you? At which point she said, okay, if he's doing better, if he seems stable. So this was back in June, and that's actually when I first met him. At this point, he seemed to be pretty stable, still didn't have very many friends at school, but was doing better at school. He had actually won Student of the Month that month. He seemed to be kind of chugging along there. They put him on different medication regimen. He seemed to be doing better. And then over the next couple months, he had a couple episodes of aggression. His parents said that he was easier to tolerate or easier to control during those than he had been in the past, but he had one at summer camp and was kicked out of that summer camp. And he continued to have missed appointments and same-day cancellations. And over the next 6 months, had only attended 3 of his scheduled 17 appointments, and was therefore then discharged from behavioral health services. So then they're kind of at a standstill. So he doesn't really have behavioral health services here, and he's kind of kicked back to his pediatrician, who now has like competing diagnoses. Is it bipolar? Is it just oppositional defiant disorder? What do we do about the medications? Do we just keep renewing them indefinitely? What happens when he doesn't show up? So he's kind of just like at a current limbo in this scenario. So that is Logan. I'll bring it back.
Thank you. So, Logan encapsulates many of the difficulties that we have, including the fact that he's one kid with one set of symptoms that have, how many did we count? At least 7 diagnoses, from what you said. So maybe he's got all those, but maybe not. So Logan probably falls into this idea that's now in the DSM-5 of other specified bipolar disorder. Maybe, I don't know without having seen him, but what the DSM-5 decided to do was they decided to pull out something that was called bipolar disorder not otherwise specified within the DSM-4, and they tried to give some specification to it. So what does it mean? It means that if you have these shorter duration hypomanic episodes, which it sounds like Logan may have had, these sort of short 2 to 3 days, they meet the full symptomatic criteria, but they don't meet the time criteria. So in order to meet a hypomanic criteria, you have to be 4 days. In order to be manic, you have to be 7 days, and Logan didn't quite get there. So maybe he would fall into this short duration idea, or he might fall under a hypomanic episodes with insufficient symptoms if he also had a major depressive disorder. So this is kids who have depression but then have these little elevations, but they don't ever sort of get all the way up to full hypomania. Or maybe you had hypomania without a prior major depressive episode. So in order to be bipolar 2, you have to have both hypomania and depression. But some people get hypomanic and have never exhibited a depressive episode, and that's the DSM-5 allows us to call them something, as opposed to what we used to call them, which was basically not otherwise specified. Or short duration cyclothymia. So in kids, you can have these hypomanic and dysthymic symptoms, right, that sort of come and go up and down, but they have to last for 24 months in order to get the diagnosis of cyclothymia within the DSM-5. So again, maybe he's oh, and I'm sorry, and that's for adults. In kids, it's 12 months. So if they go up and down for 12 months, you can have the diagnosis of cyclothymia. All this matters only to the medical students. So, because this stuff ends up being on your shelf exam, the rest of us have to deal with the real world. So what do we do for poor Logan and his life? Which we'll talk about. So this is basically what I just said in words. So bipolar 1, bipolar 2, so manic episodes or mixed. We don't really call them mixed episodes anymore. We call them mixed features. So you have an episode that has mixed features. So you have depression, but you also have some manic symptoms at the same time. Those are mixed features. So bipolar 1, you would have a manic episode. You can also have hypomanic episodes, and you can have depressive episodes, but you don't have to. All you have to do is make the diagnosis of having a manic episode. Bipolar 2, you can't have ever had a manic episode. You have to have hypomanic episodes, and you have to have major depression. And as I say, that's how we get this bipolar, this unspecified bipolar disorder, or other specified bipolar disorder, which has basically the hodgepodge, cyclothymia, major depression, of course, you have, and as long as you don't have hypomania or mania, you can just hang out as a depressive episode, which can have irritable mood. And then there's dysthymia, which is sort of, you're not in a major depressive episode, you're in a chronic depressed state, but you're never reaching that criteria to be in a major depressive episode. This is the sort of the group of mood disorders that we have in the DSM-5. And if you look at these sort of visually, it might look a little something like this, where this is mania, this is depression, and you can see in bipolar 1, it's these episodes of lots of mania and then lots of depression. Bipolar 2, lots of depression, but a little bitty sort of hypomanic. This is other bipolar, so other specified bipolar, sort of all over the place, these sort of hodgepodges. And cyclothymia is I'm sort of mostly depressed, but then I have these little blips of hypomania. That's cyclothymia. Okay, now here's a typical case. This is what we see a lot of the time in the clinic. So Henry's 12. Their parents say he's been difficult since he was in the womb. He started at about age 4. They noticed he would get more frequently moody, which would last all day in a way that was noticeable by everybody. He's constantly, almost persistently, all the time irritable. He'll get very agitated at times, becomes intrusive in the conversation, says trouble sleeping at night. He's highly distractible. He responds very extremely to negative emotional stimuli, like when he got so upset at a baseball game that he threw an hour-long temper tantrum, first on the field, then in the stands, then in the car. These types of events are not uncommon. They occur maybe 4 to 5 times a week. He really hasn't been symptom-free since he was age about 4. There have been no clear episodes. Nothing can describe his elation, just he's always this way. He's been admitted to a general pediatric service for an asthma exacerbation, but it's been a real handful for the pediatric service. His oppositionality and temper tantrums are legendary, according to the pediatrics attending, who's called the consult to rule out bipolar. Again, this is much more common for the kind of presentation we would see either in the outpatient clinic or if we were doing consultation in the general hospital. So starting, again, sort of about 2003, we started trying to study these kids a little more carefully. And it's first started out with something called severe mood dysregulation, or SMD. SMD, and it's then later, I guess, daughter, DMDD, which is disruptive mood dysregulation disorder, is now in the DSM-5. It's characterized by these things. So severe irritability, affective storms, in other words, these huge sort of temper tantrums, mood lability, temper outburst, some symptoms of depression, especially irritable depression, oftentimes with hyperactivity, poor concentration, impulsivity, oftentimes diagnosed ADHD. With or without, most often without any clear episodicity. The episodes here tend to be related to the same kind of things that episodes occur with ODD. So like an episode where they get told no, their limit gets set, and so on and so forth, then they might have an episode, one of these sort of affective episodes. But it's not just sort of out of the blue and lasting for 3 to 4 days. This is like, I told you, you couldn't do that, and you're off to the races. It's very likely, and I'll show you some data that suggests why this is true, it's very likely not a developmental phenotype of bipolar disorder. So I bring it up here in sort of contradistinction to bipolar disorder, because really, it's the thing that we're oftentimes trying to determine whether they're this presentation or whether they have bipolar disorder, because the treatments might differ, as I'll show you. So as I said, in NIMH, the roundtable, they decided that this is an alternative phenotype, and then DSM decided to put it in the DSM-5, which was kind and unkind. So they put it in the DSM-5, and here are the diagnostic criteria, which are basically what I just showed you. So temper outbursts in response that are in response to common stressors. It occurs at least 3 or more times a week. In between the temper outbursts, usually the mood is persistently negative, which can be irritable, angry, but also sad. And then the negative mood is observed by others. They can't have bipolar disorder, basically. They can't have a psychotic disorder, and so on and so forth. This ended up getting called disruptive mood dysregulation disorder, which is better than its original name, which was temper dysregulation disorder with dysphoria, which is terrible. TDDD is what we were calling it for a while, and now it's DMDD. But TDDD was terrible because parents were like, it's not a temper tantrum disorder, right? The kids do have temper tantrums, but these are really extreme temper tantrums. And that's what DMDD is supposed to be. Now, the reason why I said it's kind and unkind, it's kind because we now have a home for these kids who are persistently irritable and have these temper tantrums, and they probably are not bipolar disorder and may not need second-generation antipsychotics. They might need something else. That part's kind. The unkind part about it is they put it in the DSM-5, and nobody gave us any idea about what we were supposed to do with these kids. So now we can make a diagnosis that we have no treatments for, which, is, I guess, so if I wanted to do that, I would have stayed in neurology. I like the idea. That was the nice part about pediatric neurology, was I could make the diagnosis, but I never had a treatment for it. I like, instead, not knowing exactly what I have, but having some treatments for it. That's psychiatry. So think about that, students. So the take-home from this initial part is that we now have at least 2 types of things that would be bipolar in kids. One is you make the full criteria for either bipolar 1 or bipolar 2. And I put especially with elation and grandiosity, because for me, maybe I'm still just sort of old school about this, but I kind of believe the manic episode that has elation and grandiosity associated with it. Irritable mania exists, and I don't discount that it exists, but if it has elation and grandiosity, I'm much more likely to hang my hat on it. And then we have this other specified bipolar disorder, and I gave you some criteria for that. There are these other children who frequently are called bipolar who don't appear to have a developmental phenotype of bipolar disorder, and they're better characterized as either severe dysregulation, or severe mood dysregulation, or DMDD. And this is the biggest take-home. If there's one thing to take home, it's this. There's continued disagreement in the field about this. Don't ever mistake the field's lack of specificity for your lack of knowledge. So the fact that if you had 3 child psychiatrists in the room, as we heard in your case, if you had 3 child psychiatrists in the room, there'd be like 7 diagnoses, right? And so our lack of your own inability to make that diagnosis really has very little to do with your own lack of knowledge. It has mostly to do with the fact that we aren't really clear on this, even now, some 15 years after we started studying it. I'll just talk about this very briefly. It was this attempt to take this top-down approach to kids. So instead of, so just like the DSM is a top-down approach where like all the experts get together and they say, here are the criteria and you're now going to live with that. SMD did the same sort of thing. We're all going to get a bunch of experts together. They'll decide on what the criteria are, and here's what it is. And it came out of the work from Ellen Liebenluft at NIMH. There's a number of different studies to show that that there is some specificity to at least to severe mood dysregulation in terms of the way that the brain works with regard to it. But there's some that overlaps with bipolar disorder. I won't get into great detail with regard to that. But here's the one that I did want to talk about, which is the life course of severe mood dysregulation. So Melissa Brodman, who works with Ellen at the NIMH, went to the Great Smoky Mountains study, which is a longitudinal study in Great Smoky Mountains. And they followed up a bunch of kids who would have met the criteria as a proxy diagnosis of SMD, to follow them up and say, like, what did they look like as they got older? And what you'll see is that this is the percent of them that would have any diagnosis as they got older. A lot of them had diagnoses. Most of those were in sort of some emotional disorder, some other behavioral disorder. But I just want to point out this one. This is bipolar disorder. Like, none of them had bipolar disorder as they got older. The vast majority of them had ADHD, ODD, cognitive disorder, and depressive and anxiety disorders. So as they got older, it didn't really look like this was going to continue to be any type of a cycling mood disorder. And I'll show you some other data that support that as well. So for SMD, EMDD, it seems to characterize individuals separable from bipolar disorder, again using this sort of top-down approach. The children have some neuroscientific characteristics that are similar to kids with bipolar disorder, but most of them sort of distinguish, and they don't grow up to have bipolar disorder. So there may be something to it. Now, the downside of DMDD is that when they did the field trials for the DSM, DMDD as a diagnosis was not a very reliable diagnosis. In fact, so if you had the same person and they're evaluating the same kid several times, the likelihood of them making the same diagnosis is not that high. And certainly if you have more than one clinician evaluating the kid, the likelihood of them making the DMDD diagnosis was not that high. So it has that problem. It has the problem of not necessarily of being a new diagnosis that's not necessarily a reliable diagnosis and we don't have a treatment for. So if we had to bet on whether it's going to be a one-hit wonder in the DSM-5, it's the one that I place my bet on as a one-hit wonder, but we'll find out. The reason why they did it, from talking to the chair of the committee at the DSM-5, why did you decide to make this diagnosis? It was to reduce the number of kids who have a bipolar diagnosis. It was like pure and simple. This was the decision. It's like, we're going to engineer having fewer kids with bipolar disorder by giving you a new diagnosis to place them into. And to some degree that worked. The problem is, if you don't have a treatment for it, what are you going to use? The same old treatments. And in fact, people are now studying what happens when you put kids with DMDD on risperidone. Well, they get a little less aggressive, right? So now the people are saying, well, let's risperidone for DMDD. And so it's not solving the real problem that they wanted to solve, which was to reduce the number of kids on second generation. So I'll just point this out really briefly, just again so we can get to the treatment piece and leave some time for questions. Does anybody use the child behavior checklist with your kids? So there is a profile in the child behavior checklist that kind of identifies these kids as well. I like it because it's a bottom-up kind of approach. So rather than saying, what do the experts tell me, it's instead like, what do the parents tell me about the kid's behavior? So it's this profile that is anxious, depressed. Here, this one will show it a little bit better. So this is the anxious, depressed scale. This is the attention problem scale. This is the aggressive behavior scale. So those three scales, when they show up together, the sort of the triple A peak, as you could call it, sort of anxious, depressed, attention problems, aggressive behavior. Those three peaks in combo are the kids that we study in the clinic across the lake in Vermont, and we call these kids of having the dysregulation profile. This is just showing you again this sort of the way of categorizing these kids versus other kids with the CBCL. And so that peak is something that we've looked at, and again I'll just give you a little bit about it. So those are the kids that end up self-reporting suicidal thoughts and behaviors at least within a large general population sample. That's the girls. These are the boys, 21% of them at age 10, showing some suicidal thoughts or behavior. This is showing the genetics of it. I won't harp on this for very long, except to show that kids with this profile, so this is your additive genetics, this is the unique environment, so the things that just happen to you, the sort of slings and arrows of outrageous fortune. This thing in the middle, shared environment, that is like things that would make two siblings more the same. And that shared environment is where we hang our hats on things like rearing environment, the way that the parenting is done, the sort of overall environment in which somebody lives. And I show it to you only to point out that if you look at this age 7, 10, and 12, and we're looking at about 5,400 Dutch twin pairs, so 10,000 kids at age 7, 7,000 kids at age 10, and about 4,000 kids at age 12, you can see that effect of the shared environment drops off with age. So down here, the effect of the shared environment is really pretty high that drops off. And this effect is sort of what ODD kind of looks like. This idea that there's some intervention, some environmental intervention possibly that could happen, that could work when the kids are younger, but as they get older, that environmental influence starts to wane a bit. And in fact, I don't think I put the slide in, but if you get to adults, it's completely gone. And I'm going to skip the discordant twins, although I love them very much, but I'm going to skip them. Because this is what I wanted to get to. So if we look at the prognosis of kids with that triple A profile, or the dysregulation profile, there's been a number of groups that have looked at what happens to high-risk samples with regard to this. And what they showed in Stephanie Meyer's work, she showed increased rates of bipolar disorder, substance use, and personality disorders. But this is from bipolar mothers. So the kids were already the children of bipolar moms, so they had a higher prior probability of having bipolar disorder. A second follow-up look at ADHD, and this is Joe Biederman's work at Mass General. He showed increased rates of bipolar disorder, disruptive behavior disorders, diagnosed the Mass General way. And then the third was a German group which showed an increased risk for substance use disorders, suicidality, and poor overall functioning in a clinical sample, but not bipolar disorder. We looked at it in a large general population sample. And here's what we showed. So we're looking here at a large set of kids followed over, really it was 14 years. It followed over 24 years, but this is about 3,000 kids. And it follows them over those 14 years, and what do they look like in terms of that class of kids? They have anxiety disorders, mood disorders in adulthood. They have disruptive behavior disorders. They have drug abuse. They have some signal for suicidality, but it wasn't significant. They have major depression, but they don't have bipolar disorder. So this is consistent with the DMDD literature, the SMD literature. So these kids with these sort of irritability, this broad irritability, these affective storms, these temper tantrums, they grow up to have all kinds of stuff. But the thing that they don't seem to grow up to have is bipolar disorder. So you say that's fantastic. Now, how do I tell the difference between the kids that are going to grow up to have bipolar disorder and those who aren't? So obviously the thorough assessment is necessary, but the assessment ends up being longitudinal, right? So in kids, the assessment's going to change over time. So part of the story with Logan is also that his developmental presentation changes over time, right? So you can't always bag on the child clinicians for the fact that we give different diagnoses over time because the brain changes over that time. It's not fair. We have a moving target. So a thorough assessment is necessary. This is the key to most of it, is looking at the frequency, duration, severity, and time course. I mean, it's the same sort of things you got in your diagnostic classes. So what's the time course of the thing? Is it a change from baseline? Is there elation and grandiosity? Those kinds of things are going to push you towards bipolar disorder. Or is it more like the sort of chronically irritability kids? Assess for the type of aggressive behavior, which I'll show you in a second. And then are there precipitants? It's hard to precipitate necessarily a manic episode, except with some medication or sleep deprivation, right? So if you can precipitate a manic episode if you give somebody cocaine. I hope nobody's prescribing that. But so you could precipitate a manic episode. You could probably precipitate a manic episode with a large enough dose of an SSRI in the proper sort of brain. You could precipitate that. But for the most part, you can't precipitate a manic episode by telling somebody no, right? That if it's because you told them no, and that's not how you get bipolar disorder, right? You don't precipitate mania. So, so here's the sort of the cheap version of how do we tell the difference of whether aggression is related to bipolar disorder or to this sort of more severe dysregulation. Are these temper outbursts a distinct change from baseline? So in the severely dysregulated child, that's their way of life, right? They have these temper outbursts that happens like multiple times a week. It's not like this week Johnny is this way, and then the rest of the time he's mellow, right? It's Johnny's that way all the time. Is there elation, grandiosity, decreased need for sleep during the episodes? Right? Those are key components of a manic episode. If that's true, if that's when they're being aggressive, it's because at the same time they're elated, they're grandiose, they have decreased need for sleep, then it might be bipolar aggression. Are there discrete periods or episodes that last a day to several days? This is like, is there chronic non-episodic irritability? If they're irritable chronically and it's not in episodes, the likelihood's high that you're looking at a severely dysregulated kid, not really a bipolar kid. And does the aggression frequently occur in response to limit setting? As I said, like if it's really because you told them no, because you set a limit, because they're being required to do something they don't want to do, this is not going to be bipolar disorder necessarily. That's not to say that kids with bipolar disorder can't also get really pissed off at you for telling them no. That can happen. But if that's really the sole thing that they have, that's not it. How about differentiating bipolar disorder versus ADHD? The two things, if you believe the studies that are out there, the two things they could co-occur fairly frequently. Elation and grandiosity really don't occur much in ADHD. You can sometimes get this sort of positive illusory self-perception, this idea that the kids will sort of believe that they can do anything. That will sometimes be a part of ADHD. The idea that they are able to do stuff that they might not be able to do. But that's part of childhood too. But really not true elation or grandiosity and racing thoughts. Even though they move quickly and they talk quickly, if they have hyperactive type or combined type, really it's not as much as ADHD. Decreased need for sleep does occur with ADHD, but not nearly at the rates that it does with bipolar disorder. Silliness, laughing. Irritability, though, doesn't really distinguish between the two very much because kids with ADHD can oftentimes be irritable and they have co-occurring ODD, right, separate from bipolar disorder. But these things, distractibility, these kind of things really don't help you distinguish, right? Distractibility and high energy, that's ADHD and bipolar disorder, and rapid speech the same. All right, so what do we do for these kids? Well, in bipolar disorder, I'll show you some of the more recent data. Although this is from the ACAP practice parameters in 2007. They haven't been updated since 2007. There's a whole new way that ACAP, this is the American Academy of Child Mental Health and Psychiatry, is rolling out their practice parameters, and so they aren't updating the old ones because they've got this new way of doing it, but it hasn't gotten to us yet, so we're all kind of stuck with this. So although more controlled trials are needed, mood stabilizers and atypical antipsychotic agents are generally considered the first-line treatment. Behavioral psychosocial therapies are also generally indicated for juvenile mania to address disruptive behavior problems and the impact of the illness on family and community functioning. So that having been said, like if you're going to be putting a kid on some type of antipsychotic or a mood stabilizer, if you're going to start that, it's probably a good idea to also start the referral process to a child psychiatrist, right? Like most of the time, it's not going to be what you should be starting, but you're likely to, like in Logan's case, you're likely to end up holding the bag when they go up to the hospital and we dump them on all this stuff, and then they come back to your office, and now you're like, now what do I do? Because I've now got a kid on lithium and Abilify, and that is not what I like to do. But that is, in the end, what the recommendations are telling us. I'll show you a little bit of the data on which of these things is better. What about for dysregulation? Well, interestingly, they tried lithium in a double-blind placebo-controlled trial. Dan Dickstein did this work. It didn't work at all. And in part, the reason why it didn't work is because this was at the NIMH, they do a 2-week run-in where they take them off all their meds. Then at the end of those 2 weeks, after they're in this controlled environment in the inpatient setting off of all their meds, half of those kids no longer met the criteria for disruptive mood dysregulation disorder. So they took them out of their home environment, they took them out of the school stressing environment, they put it in a controlled environment with lots of structure and limit setting, and in those 2 weeks, they took them off all their meds, and in those 2 weeks, they could send them home. So then I talked to them down there, I'm like, but you're sending them back off their meds into the same environment, right? And they actually ended up doing an awful lot of follow-up then with their referring physicians to try to help them stay off meds as they went back. But that's the reason the lithium trial didn't work, is because half the kids had to go home because they didn't meet the criteria. There have been some open label trials of stimulant, which is not what you'd think of putting a bipolar kid on, right? If you really thought they had bipolar disorder, you might not be saying, first thing I'm starting is Adderall, right? But methylphenidate has been well tolerated. There's been a trial. As I said, this is going to happen. So now they're giving methylphenidate with aripiprazole, showing that it worked. There's been an open label trial of risperidone. And then these are the ones that I'm waiting to see the results of. So there's an ongoing treatment trial of citalopram and methylphenidate, and a trial of fluoxetine and lisdexamphetamine, where they did this sort of staged trial where they did either the antidepressant and then the stimulant, or the stimulant and then the antidepressant, depending on whether the kid was getting better with monotherapy. And I'm still waiting to see the results of these, even though they completed this last year. And then there's one trial that's ongoing, this is in Israel, looking at methylphenidate versus risperidone in these kids, which again I think will be eliminating the sort of idea that we're going to compare them head to head. But that's what we've got for DMDD right now. Here's what you've got for bipolar disorder, the ones that at least have an indication in the FDA. And again, if you're sitting out there and thinking about starting something that doesn't have an indication by the FDA, it's probably a good idea to have some referral or at least a phone call. Do you all use Project Teach at all? Anybody using Project Teach? So hopefully you can, this is a phone number that you can call in our region here where you can call and talk to one of the child psychiatrists. So if you haven't used that, you're certainly, it's a good thing to have in your pocket. So if you're thinking about starting on one of these medicines, or the only thing you can do is start one of these medicines or continue it, that's not a bad idea to make that call. But so lithium basically got grandfathered in for mania over age 12. It got grandfathered in on it was a very weak trial of bipolar disorder in kids and boys with substance use and mania, basically, and it was a relatively small trial from WashU. Risperidone for the treatment of acute mania has been the sort of the granddaddy of them all. Aripiprazole then came in really at the same time. They both got indications for autism. Then the new kids on the block: lorazepam, quetiapine, olanzapine, and acenapine. So this is Saffris, this is Latuda, this is Seroquel, this is Zyprexa. I don't take any drug company money, just so you know. Like as I'm naming them, you might recognize those other names more familiar. And this is Abilify. So these are what we have, and all of these have been demonstrated mostly in mania, except for lorazepam, which has been shown to work in depression. One that we oftentimes will see being used, or you might see patients coming out of the hospital on, is lamotrigine, Lamictal. Lamictal has an indication for adult maintenance treatment, right, for bipolar disorder, but really doesn't have an indication in kids for bipolar disorder. But it's oftentimes used in kids where we don't think that you can have, they have a bad reaction to an SSRI, and you want to still give them some help with their low moods. Lamotrigine is oftentimes used. I just point this out because I just said that you can prescribe these, so I feel it's necessary, although probably not necessary among this group, that like if you do it, we really need to make sure that we're tracking a few things. Height, weight, their BMI, their waist circumference, blood pressure, their glucose and fasting lipid profile. Like before you start these things, you're getting a fasting lipid profile, or a hemoglobin A1C. And then you're reassessing that, especially reassessing the weight and the waist circumference at 4, 8, and 12 weeks. You don't necessarily have to do the entire fasting lipid profile, but if they gain more than 5% of their body weight over this time frame, you're probably going to be looking at changing agents. And some of these agents will do that. Certainly olanzapine will pack the pounds on, as well as risperidone. This is just showing it, just so that it wasn't just me saying, but here's the randomized clinical control trials of atypical antipsychotics and kids with bipolar disorder. You can see sort of what the numbers needed to treat here are, but you can also see the weight gain in kilograms over relatively short trials. So again, these are days, 4 kilos with olanzapine, 1 kilo with aripiprazole, so a little bit less, but still, that's over 4 weeks. They put on a few pounds. And this is just showing Christophe Carrel did an analysis looking at a meta-analysis looking at the, or I guess it really wasn't meta-analysis, it was a comparative systematic review looking at the antipsychotics compared to the traditional mood stabilizers. This is Depakote, divalproex, lithium, oxcarbazine, which is trileptal, and topiramate, which is Topamax. Topamax, by the way, got its trial stopped in bipolar disorder in kids because the kids were having such a profound cognitive effects that they stopped the topiramate trial. So probably not your first choice. Oxcarbazine doesn't work. That's trileptal. That's a problem. And divalproex and lithium, they probably work, but at least in this regard, the effect sizes weren't quite as large as the second generation antipsychotics, which is why these groups have gone to the second generation antipsychotics, because they do have a better number needed to treat. So I just can't help but point out the non-pharmacological interventions, and I know that it's really hard if you don't have it available to you to really concentrate on this, but really none of these kids, if you're going to be on one of these agents, you should be in some type of other treatment, right? So these kids should really be receiving some type of family-based treatment where both the parents and the kids, even if it's just psychoeducation, where the parents and the kids are learning about the disorder that the child has. But I pointed out this idea, at least in this one here with the Dixtine trial, that 50% of the kids with SMD were discharged at the end of the 2-week period because they didn't feel irritable anymore. And this one, so this is an older trial, but 50% of those hospitalized with aggression improved with zero change other than being on an inpatient unit. So that structure that happens with an inpatient unit, the rule setting, the requirement that you get up at a certain time, you do this, and so on and so forth, that structure helped 50% of the kids with no change in medicine. And this is especially true for children from stressful home environments who have violent and criminal parents, which again, shouldn't surprise any of us. So if you go back into a very difficult environment, the likelihood of you having more aggressive behavior is going to be really high. So this is why, in general, we try to take a family-based approach where we assess and hopefully treat. I'm a child psychiatrist, but I'm also a general psychiatrist, so I can assess and treat family members. And if I have to, I'll assess and I'll treat the parents, at least when I was doing outpatient work. So these other modalities are there. Psychoeducation, I mentioned. Contingency management at least for aggressive behavior. Social skills training, anger management. Don't really have great data on them, but they're available. It's at least probably better than nothing. And parenting skills, the idea of being able to be consistent, setting up your structure and so on and so forth. All these, treating the non-compliant child, those kind of models where you're helping parents really sort of set the correct kind of limits. And I just mentioned that generally we try to assess and treat the family. So while these are just the overall conclusions, while the diagnosis of bipolar in the pediatric population is on the rise, and it's tapered off a little bit. It's sort of plateaued at this point, but it's still at a high rate. There are other reasons for the aggressive behavior. Assessment of irritable and aggressive children requires careful examination for episodes, grandiosity, elation. That chronically dysregulated kids are different probably in terms of neuroscience and outcomes from children with bipolar disorder, certainly in terms of outcomes. And that in general, our treatment at this point requires identifying and treating the underlying syndrome. So if you think it's bipolar disorder, you're going to end up being pushed towards that treatment. If you think it's this DMDD, you're going to say, I don't know what to do with the kids. But I think they'll probably do well with some type of parent training. And if they have ADHD, I'm probably going to treat their ADHD. And if they have a depressed mood, I'm probably going to treat their depressed mood. So the likelihood's high that we're going to see these trials, and I don't know this from sort of talking to the people, these trials are going to show that sequenced treatment with stimulants and SSRIs are probably the answer, at least in terms of pharmacology, for how these kids are going to be treated. So I'm stopping there. How did I do for time? Oh, 7:29. So I'll stop there and answer any questions, or Jack can answer questions about his case, whatever you'd like to do. But thanks very much.
In a young child, I mean, what are you looking for, man? Like lack of sleep would be something that's 7 years old. But how, what other behavior do you look for to identify meaning disorder?
So I think in the younger kids, and I don't diagnose this very often in the younger kids, although I have, but so it should be vanishingly rare, right? So, but if it's in the 7 or 8 year old, if you're going to see it, it should be. I really try to pin down episodes. So if their behavior doesn't occur in episodes, it's probably not bipolar disorder in that age group.
So it can be just that irritability kind of stuff, but happening untriggered in distinct episodes.
Correct. So it's going to last for a few days, and then it's going to wane. And oftentimes will wane into something that looks more like sadness, sort of more social isolation, and maybe they're not having quite as much fun with their friends or something like that. So, but it should still have an episode. So this idea, there was a while there where everyone was talking about how these kids were ultradian cyclers or something, like the kids were just always, even ultradian cycling is not that, it's not supposed to happen within a day, right? You're not supposed to have these cycles within a day. So, if there's no couple of days worth of episode, I'm really hesitant to say that to hang my hat on bipolar. Yeah.
I think that none of us really needed a study to know that there would be a 50% dropout if you got kids out of the environment where they're having problems.
I know. But it's good to have.
It's good to have.
Yeah.
For the case of the 11-year-old, and you answer it, was there thinking of that there was a role for CPS with 70% no-shows, 80% no-shows, not following through a treatment plan with clearly behind these kids? Is there a role?
Janet,
At least the mechanism of
did
getting someone.
they talk about that?
I never saw any mention of CPS. Care management was referred a number of times. We tried reaching out to family and tried having conversations with mother particularly, but I didn't see any problems.
Because sometimes it's a mechanism to get someone to actually see what's going on.
Yeah. To have at least some eyes on in the household.
And it may be unfounded, but at least there's information gathering.
And this is a kid who I would expect at some point, if they've been in the hospital at least once and they've been through so many treaters, and if they're still having difficulty at school, at some point you're looking at a SPOA referral and trying to get that kid into waiver services, right? So there is somebody in the household and they've got closer eyes on. But it's also a kid, so your point is very well taken. So they're not, the parents are having a hard time getting the kid to the clinic for whatever reason it would be. And sometimes that reason is psychopathology within the parent, right? So one of the advantages of having either a family medicine practice or a psychiatry practice is that you can assess and treat the parents as well. Generally, pediatricians are not huge fans of this, of assessing and treating parents. Otherwise, they wouldn't become pediatricians. So
we recognize that parents need help.
Right, exactly. We really couldn't, yeah. But it's nice to be able to have some place to refer them to. And in general, for example, when I was doing outpatient, so I did outpatient for 12 years at UVM, and then I'd just come over to work the inpatient unit. And we would always assess and treat the whole family. So, and we started out, we would see the kid, and then we'd say to the parent, now I want you to fill out these surveys about yourself. That didn't go over very well, because it was like I just said to them, it's all your fault, right? So instead we started with, when we first refer the kid in, we automatically assess every family, so that you have an idea. And you'd be surprised at how often, I'm sure you wouldn't actually in practice, you'd be surprised at how often the parent will engage in their own treatment for the sake of their kid, but they wouldn't have done it for their own sake. So we can sometimes use that as sort of the overall hook to get them into the treatment, which we know has to happen in order for the kids to be growing up in a better environment. Substance use treatment is the classic one here, right? So trying to engage the parent in substance use treatment when they are not in a stage of change where they're even remotely thinking about this. Sometimes you can you can sort of move them along into contemplation by talking about its effect on your child.
It seems like it would be even less expensive, it would be cost effective to pay for behavioral health workers to go and spend 2 hours in the home as compared to putting a child on Abilify for a month or two.
Without question. Yes. We don't need a study to show this. Yeah, but it's totally true. Yeah. And certainly over the long term, because if you're managing diabetes over a lifetime of a child, it's certainly cost effective to have a social worker going into the home. Yeah.
Just following that thread, you know, that study where half the kids got off the meds where they were inpatient. You know, why isn't more people doing that, going into the family home and helping, you know, the super nanny kind of thing for bipolar? You know, why isn't there more of that kind of stuff being done?
Why isn't there more? There's no reimbursement structure for it. Nobody will pay for it.
But except if, you know, nowadays it's all about, you know,
Population.
right, it's quality improvement measures.
Right.
You know, it's looking at the big picture.
You would, so, you know, what's really interesting, right, is that for the most part, psychiatry in general, behavioral health in broad terms, has been really poorly compensated and really like never at the table when it comes to talking about healthcare and primary care to some degree as well. Like they always give us sort of, you know, and we need to do more for primary care. But the reality is as you move into value-based payment, if this happens, and you move into value-based payment, all these kinds of things should suddenly be elevated to the top of the food chain, because now it's much more important to have somebody in that home than it is for them necessarily to get their Abilify or something like that. So I think it's mostly reimbursement structure that's limited that, at least at this stage, and also, at least that we found up in Plattsburgh, a willing supply of social workers is a problem. Like, we need more social workers. And certainly if we're going to move into this kind of model where we're taking care of people outside in the community, not in the hospital, not in the doctor's office, we need a ton more social workers who are willing to do this work. And we need to pay them more. All right. Well, I'm happy to stick around because I short-scripted everything. So I'm happy to stick around and answer any questions, or if you have a case or something like that, I'll stick around for a while until you're all done with me. But thank you very much for